For the latest information regarding the COVID-19 pandemic in Cupertino, please visit cupertino.org/coronavirus.
Great. It sounds like everyone can hear me, and hopefully the attendees can hear me as well. Good evening, everyone, and thank you so much for joining us on a Sunday night. My name is Allie Bay, and I am the Deputy Communications Director for the California Department of Public Health. Tonight's media availability is about the COVID-19 variant, L452R. We have 3 speakers tonight, and I'll introduce them for you now. Dr. Pon with CDPH will give an overview of the situation in California, and then hand things over to our other panelists tonight. And then at the end, we'll be happy to take questions. So the 3 panelists include Dr. Erica Pon, State Epidemiologist for the California Department of Public Health, Dr. Charles Chu, Virologist and Professor of Laboratory Medicine for the University of California, San Francisco, and Dr. Sarah Cody, Health Officer and Director of Public Health for the County of Santa Clara. Dr. Pon, we'll hand it over to you first for an overview of what's happening with this variant.
Great, thank you very much, Allie, and good evening, everyone. So we wanted to let you all know, first I want to just start and let everyone know that we have a network in California called COVIDnet, and this is a lab network with a collaboration with the California Department of Public Health and our labs, UC San Francisco, the Scripps Research Institute, Invitae Corporation, and the Chan Zuckerberg BioHub. And this network conducts genomic sequencing, which is like fingerprinting for different SARS-CoV-2 virus variants. And we have to date sequenced several thousand viruses in California. And we get notified when certain strains are noted, and this network really helps us understand what's circulating in California. So tonight we have collaborated with UC San Francisco and Santa Clara to let you know that there is a variant, again, L452R, which is increasingly being identified by our viral genomic sequencing labs. The variant has actually been detected in other countries and other states, including California, but again, is increasingly being noted here in California, and wanted to just sort of make sure people are aware of it. And we're working closely with all of these labs and our public health departments and the Centers for Disease Control and Prevention to better understand the significance of this variant. It's very early to know how it's going to impact Californians, but we're working diligently with all of these partners to do so. And again, it's common to identify these variants. As people have heard, this is different than the B117 UK variant. And it just reiterates how important, again, that we just need to continue to do all of the things we've been asking the public to do, which is to watch your distance, wear a mask, stay home and away from mixing with others, and when vaccine is available to you, to get vaccinated for COVID-19. So that's our key sort of overview and message, and I'll turn over to Dr. Chu next.
Hi, everyone. So I want to add a little bit on what Dr. Pan has remarked. So we've been doing, at UCSF, we're part of COVIDnet, as she described. And what COVIDnet is it's a consortium of both academic laboratories, clinical laboratories, and industry. There's a recent Illumina Helix collaboration to do genomic sequencing. The purpose of COVIDnet is to do real-time genomic sequencing. So what we do is we gather together as many cases, representative cases across all of the counties in California, and collectively our goal is to sequence as many of these cases as possible. And by doing so, by sequencing cases from the community, the expectation is that we would be able to rapidly identify new variants that may be of concern, or new variants that may be worth investigating during the course of doing real-time surveillance. Another aspect of the genomic surveillance is that the genomic data is provided in real time. So as we generate these viral genome sequences, we update them or upload them directly into databases. There's a very large international database called GISAID, GISAID, and we also upload the data into to the NIH databases as well. So this data genomic data is all publicly available. For those of you who have access to a Zoom link, I want to briefly share with you some of our findings. And I have just a single figure. Hopefully everyone's able to see this. But what the figure shows, for those of you who aren't able to see it, this is what we call a phylogenetic tree. And what I'm doing here is computationally, we can generate a tree that can show all of the sequences that we've generated over a period of time. So the reason I want to show this is I just want to show you kind of the this is the data that we look at to be able to identify, are we seeing an increased number or proportion of cases due to a new variant. So what you're seeing here on the screen, for those of you who are able to see it, is that this is surveillance that we've done very recently and this is in collaboration with the California Department of Public Health as well as county public health agencies. We started sequencing in November 22nd for this particular period of time, and we've been sequencing continuously up until the present. The data I'm showing to you is data up as of January 3rd. But if you take a look at kind of early on during this period from November 22nd to December 13th, roughly about maybe a 3 to 4 week period, we sequenced a total of 185 samples from patients and other individuals who were infected with COVID-19, of which we found this L452R variant in 3.8% of those samples. So these are selected. They're not, they represent sort of various communities throughout Northern California. Most are in Northern California. A small portion of them are from Southern California as well, as you can see on the bottom of the screen. And in addition to that, as a purpose of comparison, I can show you that we were sequencing as well to look for the UK variant. And the UK variant, there were 2 cases during this time period. What has happened, though, is that looking at more recent sequencing data, and this is what initially clued us in on this particular variant, is that you can see that the proportion of cases that are due to the L452R variant, which is this new variant, went up from 3.8% to 25%. And this is within less than a month. And we're currently generating data. Hopefully we'll have data later this week on the proportion of the variant as of the first 2 weeks of January. But you can see that this is why it's concerning that we have a variant that was actually pretty uncommon prior to early December, that since then is now roughly 25% of all of the cases that we're sequencing are presumably representative. One thing, though, is that I do have to caution you is that we do not have a systematic genomic surveillance program. In other words, the sequencing can certainly, our choice of what samples we're going to sequence, and then kind of the sequence volume and representation of various counties. This is essentially it can definitely be biased, and in fact, it probably is biased. So I should caution you about this. However, that being said, we have found this particular variant in multiple counties in California, including both urban counties or counties that you would consider to be primarily urban, such as San Francisco County, as well as counties that may be in more rural areas of California, such as Mono County, Lake County, et cetera. I think the other point I want to make about this variant is that we do not know about transmissibility. We do not know whether it's more infectious yet. I think Dr. Sarah Cody will shortly be talking about some data that's coming out of Santa Clara that may suggest that. But really, a formal epidemiologic investigation needs to be done to establish what we call the R naught, or the potential transmissibility of this particular variant. However, given the fact that now it's roughly a quarter of the cases that we're seeing in California, and maybe even more to the present, it is concerning that it may potentially be more infectious. I want to make one last point in that this particular variant is not is not a completely new variant. It was the first case of it was actually described in as early as May in California in Alameda County. And it actually, the first case of it in the world was actually a case in Denmark in March. So this is a variant that has been around, although it's really been very rare up until November. However, there has been some laboratory data, published data, that have actually looked at this variant in the laboratory. And the data, unfortunately, is not complete, and so much more work needs to be done, but that there is some worry that this is one of those variants that, because it's in the a very critical region of the virus called the spike protein, and then the binding site, the receptor binding domain of the spike protein, there is with all mutations in that particular region, there is a concern that will there be an effect, or is there an effect on the vaccine, on the efficacy or effectiveness of the vaccine? The data so far is very preliminary, but it basically does raise the concern that there may be some impact on the vaccine. I think that's the most I'm comfortable saying. Certainly, much more work needs to be done in the laboratory to fully characterize this variant and really determine whether it affects transmissibility and whether or not there's any impact on vaccine efficacy. So the same studies that have been raised and they're currently being done on other variants circulating around the world, including B117, the UK variant, and the South African variant, as well as a new variant from Brazil. The same studies need to be done for this variant as well. I will stop there. Thank you.
Thank you, Dr. Chu. We'll move on to Dr. Cody from County of Santa Clara.
Thank you so much. It's good to be with you all. Good evening. I just wanted to share a little bit of context and a few observations from Santa Clara County. As Dr. Chu mentioned, genomic sequencing is uneven. And so these are not as though we have the same number of samples across every county and across the state. It's quite variable. What's unique in Santa Clara County is that, relatively speaking, we do send more of our specimens for sequencing and have been doing that throughout the pandemic. Even so, it's a relatively, it's far more than other counties, but still not a large number. So probably 1,500 of our positive specimens have been sequenced by labs that are participating in COVIDNet, including our own public health lab. So what we've observed is we had just learned, we have had, as have counties across the state, of course, a number of outbreaks, and some of our larger outbreaks that have occurred, we have had those specimens sequenced, and they are this variant that Dr. Chu has described. So our next step, of course, is to pair the laboratory data and what we're learning about this variant in the lab with what we're learning in epidemiology as we look and investigate patterns of disease in these outbreaks. And so this raises the question of if there is a relationship, and if so, what is that relationship? So lots of work still to be done, but just in the interest of sharing what we know, we did want to let the public know that we have had a number of large outbreaks, and this variant has been identified in those outbreaks. So more to come, and delighted to answer questions.
Thank you, Dr. Cody. This is Allie Bay again with CDPH. So to ask a question, please raise your hand. Also, please bear with us as we work through this virtually. I'm sure many of you are more used to it than we are. Again, want to remind you that we are here to talk about the variant. If you have other COVID questions, our team would be happy to answer those questions at a later time.
So this is Hillary Armstrong with the County of Santa Clara PIO. And thank you, Allie, for helping to facilitate. If you raise your hand, could you please also enter in the Q&A the outlet you are with. That would be very helpful to us. I will begin. There is one question in the Q&A from Elizabeth Weiss. I will begin by allowing you to talk, Elizabeth, and we will go from there. Thank you for bearing with us.
There, I'm unmuted. Sorry about that. Yeah, Elizabeth Weiss with USA Today. Ignore my first question. You already answered that, which is great. One question I had, this variant that you're discussing, it sounds like you're mostly seeing it in Northern California. Is that because this is where the sequencing is being done, or do you think it's throughout the state? And is it being seen in these expanding amounts outside of California as well?
I will start as far as California, and thank you for asking that important question. As both Dr. Chu and Dr. Cody have mentioned, the sequencing is not systematic at this point, and we are lucky in California and really proud of this great network we have. And we've probably sequenced at least over 8,000 isolates in California to date with multiple different labs, as mentioned. And this finding that Dr. Chu noted was from his lab more recently. So there does, again, there's some more sequencing in Southern California. We've seen this in counties in both Northern and Southern California to date. But again, the amount of sequencing is heavier in certain areas where these labs exist and where local health departments or other labs are forwarding specimens from. And there are, Dr. Chu may be able to comment more on other parts of the country. My understanding is the other early detection was in Michigan in March of 2020 as well. And again, starting to see it in other, it is seen in other states and other countries.
Yeah, so this is Dr. Chu. I can maybe add a little bit to what Dr. Penn commented. So one is that because I showed the data for Northern California primarily because my laboratory has been sequencing of cases from Northern California. With respect to Southern California, there have been several labs that have been sequencing in Southern California, and at least based on the available data that's been published, in the made available in a public database, the proportion is actually about the same, and there has also been essentially a comparable rise in the number of cases. So it is roughly about, again, this is based on deposited data. It is roughly about 25% of the cases in several of the counties in Southern California as well. So I don't think that, of course, the same caveat that, sequencing, as I said, is not uniform. However, we are seeing the same rise in cases in Southern California. With respect to other states and other countries, most of the data is from other states in the U.S. It has been reported in, I believe it's at least 13 states of the United States, but primarily there have been a handful of cases. There have been very few cases. So, for instance, in neighboring states, in Nevada, there was one reported case of this variant that's been deposited in the database, and less than 10 in many of the other states. But again, I also have to add the caveat that sequencing within the state of California is not uniform, and that's true for within states as well. So part of the reason why we're seeing an increase of cases may also be that we're simply doing a lot of sequencing here.
Thank you. And next we'll go to Anna Berry-Jester with Health News.
Hi there. I just have a couple of quick clarifying questions, I think maybe for Dr. Chu. The first one is, I know you've said several times that the sequencing has not been systematic. I'm curious, has the sampling changed recently with the emergence of the B117 variant in ways that might impact what you're seeing with the sequencing of this particular variant? And then my other question is, I wasn't sure if you were saying that the November 22nd date on your slide was meaningful in some way, or if that was just sort of the time frame that you were using.
Yes. So the answer to your first question is has there been kind of different types of sampling because of the search for the UK variant? And the answer is yes. in that many groups have, there are a couple of ways that you can do the sequencing. One is simply a random survey. Essentially what you're doing is just simply randomly selecting representative genomic sequencing across counties, across the population, et cetera. Another way, though, is specifically to identify the UK variant. You can look for what we call spike gene dropout. So it's a rather technical term, but the idea is that you can pre-screen for samples that have ambiguous results on SARS coronavirus testing, and then that increases the possibility that you'll identify that you would end up identifying the UK variant. Now, the spike gene dropout approach doesn't work for this variant because this variant doesn't have the deletions in the spike gene drop that's responsible for the spike gene dropout that's found in the UK variant. So certain groups have been only looking, for instance, at spike gene dropouts. Now, that being said, the sequencing that we're doing does not involve this type of pre-selection. We're simply, sequencing representative genomes from different counties. So it really hasn't affected the way we're doing the sequencing or our approach towards selecting samples. However, one thing I do have to say is that probably this was identified early simply because we were very much on the lookout for unusual variants because we were very interested, and we continue to be very interested in looking for the UK variant, the South African variant, and even a new variant that was described in Brazil. So, and this sort of discovery of this variant that's now in California was sort of serendipitous. And I think the second question is there a significance in November 22nd? And the answer is no. That's just the date range that I'm showing you for the latest batch of samples, but there's no significance to that exact date.
Okay, great, thank you.
Next, we'll go to Erin Alday with the Chronicle.
Hi, can you hear me all right?
Yes, we can.
Okay, thank you so much for taking our questions tonight. I was wondering for Dr. Cody and maybe Dr. Chu too, was this variant found in that Kaiser outbreak, which was pretty remarkably large? And can you tell us about any other outbreaks, any details about outbreaks where this variant has been found?
Thanks, I can take that question. Yes, so just to put a little context around this, we in Santa Clara County have been doing more looking and thus more finding, sort of to build on what Dr. Chu mentioned. So anytime that we have a large outbreak, we take a subset of those specimens and send them for sequencing. In the Kaiser hospital outbreak, we did take a sample of those specimens and sequence them in our public health lab. And indeed, they are this variant that Dr. Chu has described. So our next step is to understand so that was certainly a very unusual outbreak with a lot of illnesses, and it seemed to spread quite fast. We are trying to understand whether the features of that outbreak are because of this variant. Does this variant of the virus behave in some different way, or does it have to do with other factors that were present at the hospital? So that is the question of the day. And we actually have a team with colleagues both from the California Department of Public Health and the Centers for Disease Control who are helping us try to figure that out.
Thank you very much.
Mm-hmm.
Next, we will go to Sergio Quintana.
Yeah, kind of following up on that, and the question of the Kaiser hospital outbreak. I mean, I guess the big concern here is how will you know? I mean, I know there's a team that's kind of going through this. How will we know if this variant is more easily transmissible? And also, if there's, if its mortality rate is higher, what kind of data points are going to be needed to be able to identify those two things?
Thanks for the question. So those really are the questions. So we know that there's this variant that's increasingly been found in California. We've found it in Santa Clara County, perhaps in part because we're doing more looking. But to really understand whether these outbreaks are behaving as they are because of the virus or because of some other conditions, we don't know. So this is a very important signal to us that we have to lean in and do a lot more investigating. And this is what public health departments do. This is what we're good at investigating outbreaks and understanding. So for example, was there some change in ventilation or some change in how personal protective equipment was used or some staff turnover or some other condition present? But what's really important is that we have to marry what we're learning in the outbreak investigations with what folks like Dr. Chu are learning in the laboratory. And that's the way we understand whether this variant turns out to increase transmission. We do not have any signals at this point that this variant is associated with anything else, such as increased severity of illness, although we of course are certainly looking for any signals to see if that would be emerging.
Great. We are going next to Raquel Dillon from KQED, and we are nearing the end of our time for questions, but we will get to as many folks as we can, probably just one or two more. Thank you. Did we lose Raquel?
Hello, can you hear me? This is JD Morris from the Chronicle, not Raquel.
Apologies. Yes, I can hear you, JD.
Thank you. I was wondering if someone could explain why, or could just shed any more light on whether, or on how much this is spreading in San Francisco. I just noticed that we were on the list of places that were affected. But my other questions were answered.
Yeah, so I can respond to that. So we are doing we are sequencing samples from San Francisco. I have been in discussion with the San Francisco Department of Public Health to do perhaps more systematic surveillance, but primarily we have been sequencing genomes from both inpatients and outpatients at the UCSF hospitals and clinics, and that's. Roughly the proportions are the same. So as of November, we were seeing less than 5%, fewer than 5% of the cases in San Francisco. But now we're seeing roughly a quarter of the infections as of 2 weeks ago appear to be this variant. And based on the limited, again, we have to do much more analysis, but based on the limited data that we have, there doesn't appear to be any specific link with outbreaks or specific exposure factors such as travel. I mean, these are really cases coming from the community.
Thank you.
Hi, this is Raquel. Can you hear me?
Yes.
Hi, sorry about that. This is a real basic question. When you see the growth from say 4% to about 25% of cases, why doesn't that tell you that it's more transmissible?
Yeah, no, it's a really good question. I mean, the reason why you can't immediately conclude that it's more transmissible. Now, I would say that it's suggestive and it's also a little worrisome, but you can't conclude that's more transmissible for a couple of reasons. One is, as I said, our sampling is not, as many of us have said, our sampling is not really uniform. So, part of it is, for instance, if we focus entirely on, if we sequence selectively cases from, say, outbreaks, which has been done in, say, Santa Clara, that doesn't necessarily mean that we're getting a good representation of the overall proportions of infections. So that gives you one example. I think the other example is there's a concept called founder effect with regards to viruses, and the general idea is that in some cases we do see strains become predominant simply because of random chance. It's just drift. It's just it just happened to be a strain that was in the right place at the right time. So, for instance, if you had a super spreader event, you could have if the super spreader event was due to primarily to the conditions of the event and not related to the specific virus strain, then you would see an increase of cases due to, say, one particular strain simply because there was a super spreader event that involved that strain. So I think that there needs to be, and this is something that both Dr. Pan and Dr. Cody alluded to, is that there really needs to be a formal, robust epidemiologic investigations that need to be done before we can really say that a strain is more transmissible. It's not merely increasing number of cases.
Thank you.
One last question from Sophia Bolag at the Sacramento Bee. And after that, please feel free to reach out to our PIOs on the press release and the media advisory for follow-up questions. Thank you very much.
Hi, are you guys able to hear me?
We are, thank you.
Great. So my question is really a clarifying question for Dr. Chu. You had mentioned that some of the very preliminary data is concerning because it suggests that there might be this particular variant the vaccine might be less effective against it. And I'm wondering, is that because the data is starting to point in that direction, or were you just saying that that's a possibility because of where on the virus this variant is affecting?
Yes. So the reason I mentioned that is because the specific mutation that we're talking about. So one thing I have to clarify is that this variant it has more mutations than just this L452R variant that we're calling it. We're calling it the L452R variant because it has one specific spike protein mutation called L452R. That's the location on the spike protein where the mutation is actually located. The variant itself actually has at least 5 different mutations. So I want to distinguish this specific mutation, the L452R, with the variant. That being said, there has been some laboratory data that's been published on L452R, that specific mutation. And the laboratory data, and this is all data in the laboratory, so it hasn't really been, we haven't really had any circulating viruses to actually study this. But at least based on the laboratory data, it does suggest that there may be an impact on how well neutralizing antibodies will bind at that position. So what that means is that if you have a virus, which is this variant that has that mutation, you have to worry about, or we are worried about the possibility that, because that mutation, that single mutation has been linked to potential an effect on antibody neutralization. Well, could the entire variant itself, which has additional mutations, could ultimately that variant have an effect on antibody, on vaccine effectiveness? And so these are exactly the same kinds of concerns that have been raised with the UK variant, for instance, and the South African variant. And this is why these are critical studies that need to be done. But the best way to do these studies, and the first step, is to grow the virus. So this is what we're currently doing right now with researchers at UCSF. We've actually put like eight samples from 8 different cases of the variant into culture. And the idea is once you have the virus growing up, you could then test it with blood from people who've been vaccinated or blood from patients. And the idea is we can get some answers to those questions directly working with the actual variant.
This is Dr. Cody. I just wanted to jump in for a moment. I think it's also really important just to understand the virus may behave one way in the laboratory and have some features, but it may behave in a very different way in real life, just like the transmissibility question. And I would imagine that this is also something that, colleagues in vaccine manufacturing are also looking at and studying these variants. But I want to make sure that the takeaway is not that we need to start worrying about this. I think the takeaway is that this is a variant that's becoming more prevalent, and we need to lean in and understand more about it. I hope that Dr. Chu and Dr. Pan agree that those are the key takeaways.
Absolutely, I agree. This is Dr. Pan, I think, and maybe as a last sort of reiteration that, to answer many of your questions, we are working diligently, again, across this great network of these excellent labs like Dr. Chu's lab, the rest of our COVIDnet network and the Centers for Disease Control, and doing a lot of epidemiologic investigation in partnership with local health departments and the Centers for Disease Control to investigate both what we're finding in actual cases in those investigations, and then the lab data, as mentioned as well. So we'll absolutely keep people updated as we learn more, but wanted to make sure we were sharing information as we learn it.
Thank you, everyone, for your thoughtful questions. Thank you, Drs. Pan, Chu, and Cody for making time to answer questions tonight. I will remind everybody that if you do have questions that we didn't get to tonight, please feel free to reach out directly to our public information officers via email. Have a good evening, everyone.
For the latest information regarding the COVID-19 pandemic in Cupertino, please visit cupertino.org/coronavirus.